There are relatively few specialists for the large number of general practitioners and pets in the world. And veterinary specialists are concentrated in specific areas, cities, metropolitan areas. There are large swaths of the country that don't have any specialty medicine within many hours drive. Specialty medicine also, because it's specialized, is oftentimes unaffordable for clients. And so it's really a two-pronged approach to bring specialty medicine to always be supporting of veterinarians who don't have ready access to specialists, but importantly, make it accessible and affordable for clients so that really everybody can access the benefit of having a board certified specialist help with the care of their pet.
Emergency medicine is just general practice, but at an Indy 500 pace.
Yeah, it's like general practice, but really sick.
Yeah,
for sure.
Exactly.
You've probably had this scenario where you've had pets come in to see you on ER that have been diagnosed with something like a hemoabdomen. And the owner knows, okay, my dog has a hemoabdomen. I need to go to the ER now. What they don't know is that hemoabdomen has a high probability of being cancer, and a malignant cancer at that. And once they get to the ER and that discussion is had, they now know this is not something they want to go forward with, transfusion, surgery, etc. And that's one of those discussions that can be had initially prior to referral and really save the client frustration and time and money too.
You got to look in the mirror and look at how you're acting when something emergent happens with your own pet, and then you know how the clients feel. Did you ever hit the point of burnout?
Yes. Being a source of calm in the storm of an emergency room is a really, really critical skill to have, because there always is going to be chaos. There's going to be people who are worried, people who are upset, financial decisions, pets who aren't doing well, pets that aren't behaving, during their treatments and making it difficult for the technicians. There are lots and lots of scenarios that create chaos, but being able to recognize that there is always a solution to the problem that you are facing is a really good way to think, I know there's a solution to this situation we're in. Let's all put our heads together and come up with what that is.
Every second counts. But what happens to the people who live in the middle of those seconds? Today, our guest here on the Irreplaceable Truths is Dr. Kristin Welch. She is a board-certified emergency critical care specialist. She is also an entrepreneur who has a wonderful organization called DVM Stat, which we're going to learn about as well. We're also going to sit down and we're going to get her opinion on, what are some of the things she sees as a problem in the profession, what she does for herself to keep her sanity, and any other tips that you might be able to give all of us in order to make it through the day a little easier will be great. Dr. Welch, it's great to see you. How are you today?
Thanks so much for having me on. I'm wonderful. How about you?
Oh, another wonderful day here in SoCal. We had rain 2 days ago. That kind of threw everyone for a loop, but we're good again. So we have snow-capped mountains, and you can see them while you're surfing on the beach. So there's no complaint about that.
Can't beat that.
No, not at all. So why don't you tell the listeners a little bit about where undergrad, veterinary school, and your residency took place?
Excellent. So I went to Michigan State for vet school. I'm originally from Massachusetts, and then went to University of Pennsylvania for my internship, knowing that I really wanted to go into emergency and critical care, and headed back to Massachusetts to Tufts for my residency. And it was kind of a full circle travel across those three areas of the country, where I got to see a lot of different ways of teaching, different ways of doing things, because of course the faculty at those universities all were trained in different areas. And as you know, where you're trained largely influences who you become in practice. So it was a really great, well-rounded education that I was fortunate to get.
Yeah, critical care do you think that's one of the hardest residencies there is?
I don't, to be totally honest. I think it's one of the most diverse residencies because, we're really trained in medicine and surgery and neurology and cardiology and expected to be proficient in all of those to some large degree in order to be able to take care of some of these really critical cases and make therapeutic decisions and guidance for the other team members in a big hospital. But I don't think it's the most challenging residency. It certainly, though, does put you to the test with the level of illness of the cases and the level of stress that the families are experiencing when they have those really, really sick patients, especially in the ICU.
So, in your experience, when is it an internal medicine case versus a critical care case?
That's an excellent question. I was really fortunate that I was trained by two double board certified specialists in internal medicine and emergency and critical care. So a large portion of my residency was internal medicine based. And that's one of the big things that I'm really passionate about. But, once an internal medicine patient becomes really unwell to where they need to be admitted to the hospital with 24-hour care and monitoring, quite often those cases end up on the critical care service so that they can have kind of minute to minute adjustments, because the internists importantly are out seeing appointments, they're doing endoscopies, they're in procedures, and they're not able to be stationed in a set area of the clinic monitoring their sick patients, which is, our home base is kind of in the ER and ICU.
Yeah, because at least, I know a couple criticalists here in SoCal, and they always get frustrated because they feel like they get to take the postoperative surgical cases. Um, I'm just curious because I never really asked him, and you clicked something in my brain. So let's say an animal comes in congestive heart failure to see the cardiologist, and they hospitalize it for oxygen. Is that still cardiology, or does that become you?
Well, it's really a team effort, to be totally honest. So that's when, we as criticalists rely on the internist for their specialty and the cardiologists for their expertise when we are co-managing those cases. And, the truth of the matter is that when you have sick patients in the hospital, it's really a team effort and collaboration among the doctors in the hospital and the technical teams is so important to ensure that the patient has the best chance of a positive outcome. We in ICU can't do our job well for these critical cardiology cases, for example, without a cardiologist aiding in the co-management of those cases.
Because if you talk to any veterinarian and you say emergency critical care, I automatically, in my mind, I don't want to say chaos. I think that's a little tough of a word. But I mean, it basically could be. You could have 8, 9 critical cases there in ICU that you're in charge of. Was there a moment that changed you forever that you can remember?
I've had cases that have really impacted how I practice. I had one case that, sticks with me as one that really just hit me very hard. And, I take care of sick patients all the time. I've been doing this for almost 20 years. And I absolutely love what I do, and I love helping as many patients through their illnesses as possible. But, of course, sometimes you're not able to have a positive outcome. And it's those cases that you think are trending towards a positive outcome that you expect are going to get better because you're seeing all of the indicators every minute of the day and hour by hour that they're making strides towards recovering. I had a young Labrador that was bit by a nest of baby timber rattlesnakes that I had in ICU on a ventilator, on antivenin continuous rate infusions for multiple days. And the dog was doing better and was critically ill on a ventilator, of course, but doing better every day, making progress. We were weaning down the ventilator settings. We were within 24 hours of tapering him fully off of the ventilator when he went into fulminant acute kidney failure. And it's just, not an unexpected complication, but one that there wasn't any indication of in the preceding days. And it was crushing, having invested, as much emotional energy into that patient as possible, really walking it side by side with the family. And then to find that we were at an impasse and a point where, the family needed to make a decision.
With that case, what did it teach you about yourself, not as a doctor, but just as a human?
This many years into practice, it's easy to compartmentalize your emotions, compartmentalize the difficulty of what we do every day, compartmentalize those discussions that, you get emotional in the minute, but you can take a deep breath and walk away and tuck it into that little suitcase and keep moving forward. And this was a case that just ripped me open. And I shed tears with that owner at the level that owner did as we were euthanizing that pet. And it was one that I couldn't compartmentalize. And so I think for me, it taught me that, there are times where your facade, that protective shell of, I can move into the next room, or I can hop on this phone call with this client and now give a positive update. Sometimes you just can't keep that all the time, because after all, we care so much. I stayed in the hospital 24 hours a day for days to take care of that pet. And, I cared just as much as his owner did in a different capacity. But it was really humanizing to know that, some of those cases just get to you so deeply.
In your opinion, what do you think the public gets wrong about a veterinary emergency room?
There's so much focus on how much emergency care is and how costly it is, and how going over things like the treatment estimate and the plan moving forward to get approval, both financially and legally, to proceed forward with care, seems from the public perception that it precedes our care for the patient, when in fact, the reason that we have to go over those things, the cost of care, what's entailed, what the alternate options are, is so that we can make sure that everybody in the decision-making process is informed of all aspects of care, all options that they have, and what the potential outcomes are from each of those options. We care so very much about every patient that comes in, because we, just like the pet owner, want a positive outcome. We want that patient to go home and do better. Nothing makes us happier than to do that for every patient on our shift. And, as that's not always the case. We have days where we have pets that are, euthanized for one reason or another, and those stick with us. And we go home and we think, what could we have done different? Or could we have potentially, you know, presented the discussion in a different way, to give them one more day to see if they could get better? But ultimately, finances play into things, because it's important for every pet owner to know from the get-go what the potential projected cost is for an entire treatment plan, and not just for 24-hour chunks at a time, because it's not practical. If a pet's got a disease that's going to keep them in the hospital for days, having a full discussion is really important from the get-go, so everybody's on the same page and there aren't any of those surprises.
I mean, I could just imagine. So what are your techniques, or how do you find calm in the storm between these critical cases, this compartmentalizing, the discussion of basically what could be big treatment plans for these owners, and these owners that are just so obviously in an emergency situation, the emotions are at a 0 to 10 about a 12. What techniques do you do, or to just keep your calm, or just keep your wits about you?
From a personal standpoint, breath work is really important. It is an important part of every day, and it's an important part of breathing through some of the really difficult situations, but importantly, being a source of calm in the storm of an emergency room is a really, really critical skill to have, because there always is going to be chaos. There's going to be people who are worried, people who are upset, financial decisions, pets who aren't doing well, pets that aren't behaving, during their treatments and making it difficult for the technicians. There are lots and lots of scenarios that create chaos, but being able to recognize that there is always a solution to the problem that you are facing is a really good way to think, I know there's a solution to this situation we're in. Let's all put our heads together and come up with what that is. And that can be in a scenario even where there's a crashing patient that's coming in the door, and the receptionist is really upset. The owners come back with the pet. The technicians are really stressed out. The pet is really vocal and painful. There is calm that needs to come into that scenario so that we can all work effectively moving forward. So if everybody takes a deep breath and has a focused role in the scenario, that really helps to move things in a positive trajectory.
So in the chaos, and we're, there are cases, they're not all the cases, but where seconds matter. Is there a checklist that you go through in your head? Because I try to tell early career veterinarians that emergency medicine's amazing because you don't really know what's going to come through the door, right? You don't have a set appointment book. And, if you live on that type of adrenaline like I love, it's perfect.
Yeah.
But I know I have a checklist in my head immediately that I go through in my head. Is there a checklist that you kind of use that's like a cheat sheet for anyone who's thinking about doing this?
Yeah, it's a good question. I think what comes with time and with seeing cases frequently in an urgent care or emergency type setting or with years of practice is that you to establish pattern recognition. And pattern recognition is such a important skill to build and grow as you're in this field. And you know this, like especially because you do ER and urgent care.
Oh,
In
and general practice. I mean, yes,
yeah.
you could say you keep licking the feet, chewing the butt wheelies across the floor, all those, you just start seeing it. And the funny thing is, like, I really think, like, especially for general practice, the senior year should be like half internal medicine, half dermatology. And I think you'll be set for general practice.
Honestly, I did general practice relief off and on over the last couple years, and I really enjoy it. But boy, is it a different from what I do on the daily basis. There is so much dermatology, so much early internal medicine, diagnosis and working through the initial treatment steps with clients. And, these clients in general practice aren't prepared for these things like they are when they get referred into a specialty hospital. So the frontline practitioners, the general practitioners, are really in a difficult position where they have clients who think they're coming in for a wellness visit only to find out that their dog has a disease that now has chronicity to it and something that's going to require treatment and cost and follow up. I really give huge props to how well rounded all general practitioners are because they really are the jacks of all trade.
Well, it sounds like criticalists are, but at a different level, because you said you had to do surgery, internal medicine, cardiology,
Yeah.
all those fun things. So I really think emergency medicine is just general practice, but at an Indy 500 pace.
Yeah, it's like general practice, but really sick.
Yeah,
For
exactly.
sure. I mean,
Yeah.
they're really like very, very minimally removed from each other. They're just extensions of each other, which is why, there is so much collaboration that happens between ER doctors and general practitioners. Ultimately, we want all of our ER cases to be able to go back and be managed by their primary care vet. And that collaboration is so extremely important.
Yeah, it's well, communication all around is important. And speaking of communication, how important is it for the general practitioner to not only stress how important it is for their pet to get over to critical care, but also discuss the cost with them before they get there?
Yeah, that's definitively a scenario that really helps to ease a lot of client stress and frustration that comes with a referral in a surprise manner. A lot of these cases that are being referred in, especially to emergency, it's an urgent situation. The client wasn't prepared emotionally, they weren't prepared schedule wise, they weren't prepared financially because they didn't know that when they walked into the general practitioner's office that day that something was wrong. When general practitioners or the primary referring veterinarian is able to have a preliminary discussion with the client about this is what I what I think is going on based on my diagnostics, or this is what I've diagnosed, I need you to go over to the emergency room where your pet can be admitted to the hospital and treated. And likely they're going to be in the hospital for, X number of days. And based on the hospital, it's probably going to cost X number of dollars. It really helps to take away a lot of that initial stress, because the client then is empowered to decide, is this something I can do? Or is this not the right decision for my family? As you know, you've probably had this scenario where you've had pets come in to see you on ER that have been diagnosed with something like a hemoabdomen. And the owner knows, okay, my dog has a hemoabdomen. I need to go to the ER now. What they don't know is that hemoabdomen has a high probability of being cancer, and a malignant cancer at that. And once they get to the ER and that discussion is had, they now know this is not something they want to go forward with: transfusion, surgery, etc. And that's one of those discussions that can be had initially prior to referral and really save the client frustration and time and money too.
Yeah, and the one little piece that I think a lot of people forget about the hemoabdomen is that, let's say it's a ruptured splenic mass. If it's a liver mass, you're done. It's over, right? But if it's a ruptured splenic mass, you can go in there and get the spleen out, but you've already metastasized throughout the abdomen, those tumor cells.
Yeah. It's,
And
you know, and that's totally, an important point. And even though the latest literature is looking more towards closer to like a 50% chance of being malignant at the time hemoabdomen is diagnosed, it is still something that's really, really important for a client to know, because for some clients, 50% probability that something is not malignant is great odds. And for other clients, a 50% probability that it is malignant is way too high of a number for them to financially invest a large sum of money into going forward with something like surgery. So it's such a personal decision. And having been in general practice, doing relief at a busy practice, I recognize that there is not much time when you have these sick appointments to be able to have these discussions. And that's another aspect that I think a lot of emergency doctors don't realize, and don't have the true perception of that. General practitioners are working in like 15-minute slots, 20-minute slots, maybe a 30-minute sick appointment work-in slot. But once that time frame is up, there are rooms loaded up and you need to move on and go to those rooms. So you don't have the liberty of having a 45-minute discussion with your sick general practice appointment to discuss all of these aspects in as detailed a way as someone in the ER doctor realm does, because ER doesn't have appointments. You can spend an hour with somebody and then somebody else ends up waiting, but in general practice it's not quite the same scenario. So there's two aspects to it that are really important to keep in mind. General practitioners work so hard and on such a strict schedule that we have to give them grace too, that there sometimes just isn't as much time to get into all of the details of some of these scenarios before referral.
that's so great that it's going down to 50%, because I always used to tell owners of dogs it's a coin flip. We won't know what it is until we get in there. And, that usually helps come up with the answer. But it's not just fixing that ruptured spleen and getting them through. Then you got the possibility of IMHA, which I had in about 2 or 3 of the cases after I did that.
Yeah.
It just goes on. And also like a GDV, then you got to watch the heart. I remember I fixed a GDV. The dog was hospitalized for 4 days. It was doing great. It walked out to the car and just dropped dead.
Oh my gosh.
And
Yeah.
there was no evidence of VPCs at all in the EKG. And I was just like, those are the cases that keep you up at night. And you still remember those cases. Everyone has them.
Yeah, those are the
Obviously,
cases that stick with you for sure.
yours is the yellow lab.
Hmm.
You'll never forget that,
No.
right?
And it's good, in a way, those cases are ones that make you a better practitioner, because you spend that extra time going back and determining, was there something different that we as a team could have done therapeutically? Was there anything different that you could have done diagnostically? Was there a different discussion that needed to be had to try to incorporate this, for instance, your complication, into the scenario that happened? And being able to be self-reflective and look back and determine, was everything that I did, absolutely everything that was possible, is not only a great quality to have, but it's also one of the things that leads to so much emotional stress in veterinary medicine. It is not fluffy puppies and cute meowing kittens that we see and take care of every day. These are family members and tied to humans who love them like their own children. And there's a lot of emotional stress that comes with all of these patients, and we take a lot of that home with us.
We do. We do. And then it gets worse when your own pet gets sick. Oh, those are the worst.
Yeah, those are
Oof.
challenging. I
Oof.
mean, it's heartbreaking because we know too much.
Yes. Yes. Yeah.
Yeah.
Well, I mean, we're the worst. We're the worst, right? Because you feel a small lump on your dog, and you all of a sudden are like, rushing to the hospital at 10 o'clock to aspirate it, maybe take chest fills, blood work just to get going because you're so worried about it. It turns out to be a lipoma, but
Yeah.
we've all been there. We've been there. Yeah, I understand. Now when you do critical care, it has got to be so hard, especially when the entire family's involved. Are there times that the parents are there and they want the kids to be there? Are there times where it's just the husband or just the wife and decisions need to be made? And how do you work through that?
That's a really good question. The hardest one for me is when the family wants young children to be involved in end of life care. I think that's a really emotionally challenging situation and really hard for young kids to understand what is happening and why it's happening. As a mom of three, that's a really really tough one for me. We do a lot of FaceTime during these sick hospitalizations and sick times and end of life care too, for families that can't all be in the room at the same time. And being able to have people visit when we know that their pet is really critical and may not survive or is terminal, I think is extremely important. I've told owners that I really think if you can visit 2 or 3 times today, or if you can sit and spend the afternoon in here, it's a really good idea, because I don't know what tomorrow is going to look like. And you want them to be able to have that quality of care and the time to spend and create memories that they wouldn't otherwise get if they were just coming in for a 5-minute visit at the end of a busy day. I love I've always loved having families just sit and spend time in the ICU, and they'll just sit there with a book or a Kindle and snuggle up on a comforter with their pet, and we work around them.
Yeah, I was always big into the sunshine therapy as well. Like,
Oh my gosh, I love sunshine therapy.
yeah, it,
Absolutely. Like, I would put it
it's
on
huge.
treatment sheets. Yeah, just go outside, even for the dogs that can't walk. Just go outside on a gurney. We lay on the grass with them on a blanket, and sunshine time is so super important.
Right. It is, and it's sad to see some of the relief shifts I'm doing that they don't believe in that. They don't believe in
Mm.
having the parents there. They don't, and sometimes I'm wondering, has the profession lost its empathy, or is the profession just so emotionally drained that we don't have empathy anymore because we just don't have energy for it?
I honestly think veterinarians are truly some of the most empathetic people, and technicians absolutely the same. I think, though, that there are situations where the schedule, the time, the caseload doesn't allow for some of the extras. Allowing a client to sit in a cage with their pet for hours, could potentially be considered disruptive to workflow. I personally feel that it's extremely important to the patient's quality of care and ability to heal from whatever they're going through. But it is tough in some scenarios to be able to allow for those extras. And when there's a really high patient load to tech and doctor ratio, it becomes even more difficult to be able to prioritize extras like sunshine time and snuggle time and things like that, because there's only so many hours in a day, and every patient deserves the same amount of care. And if you're just stretched so thin, I think it can look like there's a lack of empathy, but truly it's just that there's not enough bodies in the building to take care of the patient load that's there.
Have you seen veterinarians, I don't want to say overdiagnose, but overstate how bad a situation is just to scare owners into treatment?
I honestly haven't. In the scenarios I've been in, I think sometimes we spend a really long time talking to the clients about all of the aspects of a disease, which, when you're talking about a disease, for instance, like Addison's, most dogs with Addison's do fantastic. They live a normal life, they get their meds, they're happy, they're totally normal on the outside as long as they get their medication. But you have to talk about Addisonian crisis and other potential complications that can happen with a disease, which you know everybody perceives the information that they're given to them in a different way, and the level of stress during a conversation can really impact how a client absorbs that information. Do they absorb the positive aspect that you're telling them, or do they just grab onto that negative possibility or the negative aspect of the prognosis, and that's really all they hear from you? And I think that there is some bias that can happen there depending on the scenario that you're in. But I truly don't think that as a profession anybody aims to strong arm somebody into doing diagnostics or treatment.
Oh, wow. Yeah. And well, I was also thinking too, do you believe, I totally believe in this myth that, the worst things unfortunately happen to those of us who work in veterinary care. Like, because you just mentioned Addison's, and it brought me back to my standard poodle who was atypical Addisonian, then became Addisonian, then bloated. Thank goodness I did a prophylactic gastropexy on that dog. Then got DCM and passed away at 7.
Oh, that's awful.
Right.
Yeah, we have really bad luck as vets. We really do. My dog was a Labrador. He had a ruptured right adrenal tumor and presented as a acute large volume hemoabdomen. Like, of all things, it's not common.
Unicorn.
And
It's a unicorn case. Yeah.
for sure. And he had emergency surgery and went on and lived another year before he developed a liver tumor. But, we are magnets for really complicated cases, which means that those pets are so fortunate that we are their parents.
Yeah, exactly. We get just as emotional and freak out just like all of our clients. And we can't say we
Absolutely.
don't. We cannot say we don't. You got to look in the mirror and look at how you're acting when something emergent happens with your own pet. And then you know how the clients feel.
Absolutely.
Yeah. Did you ever hit the point of burnout?
Yes. And it was one that truly made me reflect on why I love what I do and why this has been such a big component of what I identify as. My identity has always, largely been, in addition to being a mom and a veterinarian truly being someone who just absolutely loves their career as an ICU vet. And when I hit that point where I was working 80 plus hours a week on call, 4 nights a week plus every other weekend, and raising three tiny humans at the same time, it was just a lot. And burnout, I think, presents differently for everybody. For me, it was really just getting to the point that I felt like I didn't love the idea of going back to work the next day, where I have always, since the moment I got into vet school, loved going to work the next day, loved going to work in the morning. Like, I looked forward to it. And even on my days off, when I was out like doing fun things and hanging out with my kids and with my friends, like, be like, great, I get to go back to work. It's Wednesday tomorrow. And I loved it. And when I got to the point where I didn't feel like that, and I started to feel stress and have trouble sleeping, I realized that I needed to just lighten the load a little bit and reprioritize what it was that I loved about my job and what I wanted the next phase of my career to look like.
Did it cause any chaos in your family life at that time? Because, you're so emotionally drained. Do you feel you're as if you're giving your family what was left to you, not what was best of you?
Yeah, that's the hardest part about when you're in a emotional burnout state, is like you're wiped, and the energy that you normally have to be able to do fun things and be the fun person who goes out and is playing at the playground or like at the aquarium having a good time, like you don't have that anymore. And so the smile's not natural, your joy's not natural, you're not laughing as much as you normally would. And yeah, it trickles down, which is why in veterinary medicine especially, where burnout and compassion fatigue are just so prevalent, it's really important for people to be able to look inward towards themselves and determine, is there something that I need to change about my current situation to be healthier? Mental health is just, it's so extremely important. And it's really hard when you're in the weeds of a busy practice and, you've got everybody else's priorities outlined. You become the last priority in your own life, and it just can't be like that.
Yeah, and just for all the listeners, just to truly understand, because I know a lot of people hear the word compassion fatigue. Compassion fatigue is just a next level of burnout. You have gone through burnout, which basically means you're emotionally exhausted. You have totally cut yourself off from everyone else, and you don't believe in yourself anymore. And the compassion fatigue point comes into play because you're so emotionally involved with the families that are making very hard decisions for their pets. And that's where so it is part of the burnout thing. But I think a lot of people try to separate it, and you can't. You know, the researchers out there are saying that, and they only use compassion fatigue in nursing and veterinary medicine. Those are the two places they use it.
Hmm.
Just yeah,
Yeah.
it's crazy because you think about it, right? The nurses are so emotionally connected with their patients in a hospital because they have the families there, the kids there, the grandparents there, the in-laws there, the blank there, this there, and the nurses are always in there talking and just listening to stories, and that's kind of what we do every single appointment.
Yeah.
Yeah,
Absolutely. So much of veterinary medicine is people medicine. There are people that say they want to go into the veterinary field because they don't like people. You have to be a people person to be in
mistake
veterinary
number
medicine
one.
because, yeah, 75% of our job is working with the families. And you get to know, even in some of the, in emergency and urgent care, like you see people maybe once or twice, potentially three times, but you don't see them for years and years, but you still get to be part of such an intimate moment with the deep emotions and the peripheral situations that come into that decision making process, that you do have to try to create like a separation between yourself and the situation that's in front of you, because some of the families have such hard scenarios that they're going through concurrent with now a catastrophic situation with their pet. And like in general practice, that like you've known these clients for years. And so you are an extension of their family. And that makes it even harder.
Yeah, it is very hard. So you're going through this. Was it during your burnout or after your burnout that you've came up with this DVM stat?
So unrelated, but in a cool way, they kind of sort of melded into each other. So DVM stat came about as an extension of something that I had been doing at the practice I was at for a decade, which was really working as a resource to the RDVMs and trying to grow our referral base. And so, as part of that, being a phone consultant for those veterinarians, um, I talked to vets from 3 surrounding states on nearly an everyday basis who were calling in with case questions and blood work questions and complicated anesthetic scenarios and cardiology patients that weren't doing well, and you name it. And I absolutely loved doing that. And I loved getting to know all of these vets over the phone. And so the idea of being able to create a service that was larger than over a small geographic area, but now national, is what DVM Stat started as. And when we launched in 2019, it was really the only service that existed that was able to provide specialty teleconsultation vet to vet across a number of specialties and make specialty care accessible now to vets who geographically or financially just didn't have the means to be able to send their clients.
So do you think what was the gap or the broken piece of the system that you truly are trying to fix?
There are relatively few specialists for the large number of general practitioners and pets in the world. And veterinary specialists are concentrated in specific areas, cities, metropolitan areas. There are large swaths of the country that don't have any specialty medicine within many hours' drive. And specialty medicine, also, because it's specialized, is oftentimes unaffordable for clients. And so it's really a two-pronged approach to bring specialty medicine to always be supporting of veterinarians who don't have ready access to specialists, but importantly, make it accessible and affordable for clients so that really everybody can access the benefit of having a board certified specialist help with the care of their pet.
How do virtual specialists change the outcomes of these cases that are hours away from specialty?
Yeah, there's a really great study in cardiology patients showing that cardiology co management between a general practitioner and a cardiologist extends the lifespan and improves quality of life of cardiology patients. And that's super cool. That's the first systemic study that's really looked at how teleconsultations impact survival. There's also a really neat study looking at dermatologists co-managing cases with general practitioners that show improved outcome as well. When general practitioners have resources available to them, they are empowered and supported in tackling more complicated cases than they might otherwise want to do if their resource is, a information network or a faculty member that they have the contact of that they were in touch with when they were in vet school. Being able to work one-on-one on a daily basis with a board certified specialist allows practitioners to expand the services that they offer to their clients.
It sounds expensive. Is how much that's what I think about talking to a bunch of specialists. How much does it cost a veterinarian to get a case with internal medicine?
Yeah, so internal medicine, cardiology, neurology, oncology is $120. And that includes a follow up consult within 21 days. So when you look at cost of care, it is less than what referral would be. And that's on purpose. The goal is to bring specialty medicine to everybody who wants to access it. And you couldn't possibly do that if you made it cost prohibitive. So our fees are intentionally very, very low so that veterinarians can offer this to clients who absolutely love their pet and want to give them the world but don't have that financial means to go physically to a specialty practice.
Are there any big misconceptions about telemedicine in the veterinary field?
So there are some areas of confusion that are easy to have, but telespecialty is a veterinary to veterinary consultation. So there are no VCPR laws that prevent a vet from any state or any area of the world from contacting and speaking to a licensed veterinary specialist. So B2B consultations between a vet and a vet are allowed regardless of state lines. What's important is that the primary care vet or the ER vet or the urgent care vet or the other specialist who's consulting with the teleconsultant needs to be the one who's communicating with the client. They have to have a valid VCPR and an exam within the last 12 months. And so as teleconsultants, you cannot communicate with the client because we are unable to establish a VCPR. But when we're working with these veterinarians, they have that client they've been working with. And so they're seeking board certified specialists, consultative, collaborative medicine so that they can amplify the level of care that they're offering. And then they, as the primary care doctor, are physically discussing the details with their client.
Do you believe this is the way that ECC and some of the specialties will be going, or you basically are being a disruptor?
That's a good question. I think that there is currently in certain specialties difficulty filling all of the slots in the residencies. And so there are certain specialties where residency slots are open every year. ECC is one of those. I don't know why everybody doesn't want to become a criticalist, because honestly, it is the most fun position in the hospital. And I mean that from the bottom of my heart. I absolutely love being a criticalist. But, it's tough when you look at the number of hospitals that there are and the number of specialists in the board certified realm. There aren't enough of us to go around to be at every facility. And so we work sometimes with big specialty hospitals that are just missing a specialty, and we become their virtual specialist for the specialty that they do not currently have on staff. And what a cool way is that, to be able to offer all of the services that you want to offer at your hospital, but do it in a way that's got low overhead. And you are working now with a virtual telespecialty group. There's so many creative ways um, to have teleconsultation be a big part of practice and to amplify your offerings.
So your license doesn't matter. You could go all 50 states.
Correct.
Wow. That's a big loophole there. That's awesome, because California is very stringent. New York is very stringent, or at least they used to be, about who can practice and who can't practice within the state. But if you're doing a consultation that doesn't go against your license, or how does your liability insurance look at this? Or there's just so many questions I have now.
Yeah, so liability insurance, the insurance provider has a rider that covers teleconsultation as long as you're working with a veterinarian that has a valid veterinary client patient relationship. That veterinarian with the valid VCPR is the one who's ultimately determining the validity and the applicability of the recommendations. You are just providing consultative guidance. Think of a radiologist reading radiographs.
Correct.
They read from all over the world.
They do.
And they're reading rads for a veterinarian in, some state in the US, but the radiologist might be in the UK or Germany. They're providing a consultative opinion on the set of radiographs that they're reading, but the primary vet is determining the applicability of that interpretation and then applying it in their discussion with the client.
And is that the key word, opinion? Like, are you giving your opinion about the case?
Yeah, we're providing a consultation based on the information that's provided to us. And so absolutely, since we are not physically there with the pet, we cannot physically repeat the physical exam. We cannot repeat the ultrasound that was done. We can't see the respiratory pattern and assess how that patient's doing over the time frame. We're relying on the data that's provided to us. Absolutely, it's an opinion based on the information that's available at the time of the consult.
Yeah, I basically, is there a rule that ECC has that you just think doesn't apply to the real world?
I don't believe so. I mean, emergency critical care is such a diverse specialty that we really focus on the immediate problem at hand, and um, sometimes can't get too far in the weeds with some of the more chronic conditions that don't immediately apply to the problem that is present in the patient right now. So, for instance, if you have a patient with IMHA who has a chronic atopic dermatitis that's not been treated, our focus is saving that patient's life with IMHA, providing them transfusions, getting to the bottom of what caused it. The atopic dermatitis kind of gets scooped under the rug temporarily until
But
that
the
patient is
atopic
stabilized.
dermatitis will be taken care of with all that pred.
Yes, maybe not a good example, but absolutely.
It's a twofer on that one.
Yeah. One of the things that in emergency is really important is not to get tunnel vision, because you do have, this life altering problem that's happening, but you have to maintain an eye for all of the other aspects of the patient's health that may or may not be contributing and may or may not be negatively or positively affected by the treatment that you're starting.
So it's very important. I mean, we tell, everyone I mentored and all the young vets, young professionals I talk to, I always like, you got to treat the patient, not the disease. Do you
Mhm.
feel that criticalists sometimes get into that tunnel vision?
Oh, it's a really difficult question because, there are scenarios where you need to separate looking at the patient from a general standpoint. What was this patient's quality of life prior to the scenario that we're in right now? And a good example of that is a patient that needs emergency surgery. And maybe it's a 14-year-old animal. Maybe their quality of life wasn't good prior to when they got sick. And that's something that getting tunnel vision and getting stuck in the weeds can be really, really hard. I always like to ask clients, and especially if I have any concern about the patient's quality of life or potential quality of life after the treatment, I always say, if you think back to 2 to 4 weeks ago, what would you say his quality of life was? Because he wasn't sick 2 to 4 weeks ago with the current problem that brought him in right now. He would have been hopefully running through the yard with a tennis ball in his mouth if it's a dog, and following them around the house and trying to eat snacks off the counter and all the things that bad dogs like to do that tell you that they're healthy. But if
That doesn't make them bad. It just makes them spoiled.
maybe just mine, counter surfers, not good. But, if the client can't confidently say a month ago his quality of life was great or good or satisfactory, then that really helps to unveil some bigger concerns that need to be dealt with before we deal with the urgent problem that, has a life threatening prognosis associated with it. I think quality of life is just so super important, and sometimes it's really difficult when you're in high stress situations to remember that that patient. Yes, of course, we can treat pretty much any disease, but if that patient's not going to have a good to excellent quality of life afterwards, that is something that we need to discuss with the client.
So do you think there's a lot of times that intervention just equals prolonged suffering?
I think it's hard. I don't think it's a lot of times, but I do think there are scenarios where, sometimes the limit of when it's okay to say it's time become um, fuzzy, and where clients need help deciding that, because end of life care is always a challenge, and it's exceedingly emotionally charged. And then when you're faced with something that's acute, we need to make a decision today about whether we treat X. Sometimes the quality of life part just gets missed, and it's not intentional, but it's part of the challenge that we deal with, knowing that you as a veterinarian and I as a veterinarian are relying on the client's perception of their pet's quality of life and helping guide them through these decisions. Because we didn't see the pet maybe a month ago to know how healthy they were. We're seeing them now while they're laterally recumbent and very, very sick. And it's a totally different picture.
Have you ever had to deal with any ethical dilemmas in your history of 20 years?
I mean, I'm sure I have. The hardest thing, always is in deciding, are we doing the right thing for both the client and the pet? Because there's two members of our team that we are treating. We are treating the pet for the client, and both of them, their follow through in what we're recommending, their ability to move forward with a treatment plan, their ability to take on a level of treatment that's required to take care of, for instance, a chronic disease. It requires both a pet that will be compliant and a client who has the ability to take care of something that maybe requires twice a day injections. I think that it's always, part of what all of us as veterinarians have to do every day is determine if the recommendations that we are making are the right ones for this client situation and this pet situation. And that's part of where, spectrum of care is so super important. And that's being able to discuss all of the options that are available to that client and what they would mean in terms of level of care, in terms of potential cost, and in terms of prognosis, so that the client has enough information to be able to make the best decision for them. And we're the guide.
So let me give you a case, because this is a case that hit me hard in veterinary school, and it taught me early, but I would like to know how you would tell early career professionals to handle this. You just diagnosed a cat with diabetes, and the owner says, I cannot give insulin at all. I don't want to give insulin. It's not what I want to do. I just want to take the cat home. What's your recommendation?
Well, we have more tools now than we had a few years ago because we have the
Thank you for being kind. It was just a few years ago. That's right.
Yeah.
That was in vet school.
But we have the oral hypoglycemics, in the last year or two. So that's a different scenario. But, that's a situation truly where, as a veterinarian, it doesn't even have to be an early career vet. We've all been in that scenario where we have a client who has a pet who has a disease that requires treatment, and they are ill-equipped to give it because they don't have the schedule. They work 12-hour days and they're a nurse, or they travel for work and they're not predictably home, and their pet's in the care of a pet sitter or somebody who pops in the house twice a day to check on them. That's a situation where a diabetic pet isn't going to likely do well. But that's a really important role of ours, to be very honest with what will happen as a negative outcome in a patient who's untreated for diabetes. And it can be difficult when you're just starting to get comfortable with having conversations with clients about difficult scenarios, to be able to paint the negative picture that needs to be painted in that scenario that you're providing. Because a client needs to understand that their pet will get sick. In that scenario, if they weren't giving an oral hypoglycemic or injections, their pet's going to develop DKA, is going to suffer, and ultimately will not survive. But it could be prolonged, and their pet will just suffer and do unwell for quite some time before that occurs. And it's just not fair to them. So that's a situation where potentially rehoming, or if needed, humane euthanasia would be the options that would be discussed. And they're challenging scenarios. It's heartbreaking.
Oh my God. Yeah. Like my palms just started sweating thinking about it, because, towards the end of my career, the whole euthanasia thing, I believe personally, there's only so many you can do, and everyone's number is different.
Yeah.
And I never, ever, ever have held it against anyone when they say I can't do a euthanasia. And I find it funny I say that now, because when my partner retired, he's like, he was 48 years. He was a veterinarian, and he was an amazing guy. He's still around. Dr. Hamill, I love you to death. But I go, well, how do you feel on his last day? And he's like, I am just happy to say I'm never going to have to euthanize another animal. And I thought to
Yeah.
myself, yeah, you're going senile, old man. But I was there. 15 years later. It hit me. It totally hit me. It hit me hard too. It still does. And it all started with that case where I was in vet school and clinics, and they had to convince the owner to euthanize the cat right there on the spot.
Hmm.
And it's just like, that is just such, because you can do so much for this animal, or at least try to help
Yeah.
it and see how it responds. But when the owner doesn't give the animal or yourself the chance, it's heartbreak. It's like a knife right into your heart.
It really is. And I agree with you. I think euthanasia becomes harder and harder and harder the more years you are into this. It's an impossible thing to um,
Keep
almost,
compartmentalizing, as you said.
yeah. Absolutely. Yeah, I find that I have a harder and harder time compartmentalizing, and I get more emotional with each euthanasia, because it just starts to kind of chip away at your ability, because you know that in every one of these scenarios that family's going home to an empty dog bed or an empty cat tree, and it's heartbreaking. It really is.
Yeah, I don't even want to think about it. So, and you talk about teams a lot. You really believe that veterinary medicine is a team sport, which I 1000% agree with you.
Yeah.
How can teams work together to hide the invisible injuries that this profession can do to us?
I think it's so important for veterinary teams to be able to talk openly about the challenges that we have, and debrief after difficult scenarios, and discuss openly how they're feeling about, whether it's a complex client interaction or a really critical patient, or a pet that you've been taking care of for 10 years and GP who suddenly now is sick, and it really hits everybody extremely hard. Um, Teams just have to be able to check in with each other. And I think, there is no weakness in being able to say, I need to take a break, or I need to go outside and get 5 minutes of air because I feel really sad after what we just had to do. Um, and having your team be able to support that and check back in with you and make sure that you're doing all right, is imperative to having longevity as supportive, collaborative colleagues, which is really what the whole vet team is. Whether it's technicians, assistants, veterinarians, we truly are all colleagues, and we're all working together towards the same goal, and we're all one team.
How much autonomy did you give your technicians to talk back or ask questions about cases? Because I gave them 100% because I love that,
Hmm.
because
I
it would keep
absolutely
me,
love it too.
yeah, because it would
Yeah.
give me, number one, selfishly, it would be like, oh, they're really paying attention to this case,
Yeah.
but also would make me think and make sure I'm not missing something.
That is the best point, is absolutely, if your technicians feel empowered to ask questions, to double check you, to bring up points like, hey, did you remember to double check that patient's PCV from 4 hours ago? Because I noticed it was a little bit lower, and I just want to make sure you saw that. The odds are pretty good that maybe we didn't see it because we were working on 10 other things. 100%. I've always felt that my tech team should be double checking and asking questions and being the second set of eyes and ears for all of these patients. They're often the first line to identify problems for hospitalized patients because they are the hands on the patient, the eyes on the patient, the ears listening to the changes in breathing patterns. And there is never a scenario where a technician, an assistant, or another team member shouldn't feel comfortable saying, hey, did you double check this? Or do you mind taking a peek at this patient? I'm a little bit worried about how they look.
If a veterinarian's listening right now and they're suffering from self-doubt, what would you tell them?
We all have been there, 100%. Self-doubt is a mechanism that allows you to learn more and do better and improve. Self-doubt should never be a scenario where you feel like you are not worthy of being in the profession or not worthy of being in the role that you're in. And so much of it is the team that's around you. You know, if you are suffering from self-doubt, but you have a trusted member in your veterinary crew or team, or a trusted colleague that you can talk to about it, the odds are exceedingly high that if you mention it to somebody that you trust and who cares about you, they will mirror that they have been in that exact same situation. So self-doubt, everybody, no matter where you are and how far into your career you're in, we've all been there. And I don't know about you, Dr. G, but like, you know, even years into practice, when you get popped into a different type of practice, it can be disconcerting and make you have self-doubt. Like, do I know enough to be in this practice on this day? Or I'm a little rusty because I haven't been in general practice for 10 years, but here I am in a general practice shift. Am I good enough to do this? And that, you know, it happens to everyone. It really does.
Well, I just think going critical care to like general practice, and it's just because I have so much respect for specialists, especially the criticalists. That's kind of like a downshift. It's kind of like, you just could slow it down. You're going from that, crazy hustle and bustle to something that is just more straightforward. You know what's coming in. You can see what's on the. Don't get me. You got your walk-ins and your emergencies here and there, but usually for the most part, you know what's coming in. And so I would think for you, that would be more of a mental reset. Is that wrong to think that way?
The schedule of general practice is the part that is vastly different from critical care. Because, you know, if you think about ER and critical care, it depends on what comes in the door and what enters into the ICU. So you don't really have a schedule per se. But with general practice, where it's so extremely regimented, that is a huge adjustment every time because those long winded conversations where you would normally sit and talk to the new diabetic owner for maybe 40 minutes about the disease, you've got to truncate that into a 15-minute discussion and then email them a detailed summary afterwards to take care of the extra piece that you weren't able to take care of during your finite period because now the room next door is 5 minutes behind.
But I
So
love that.
yeah,
I love that the virtual specialist said email a handout. I love that.
yeah. I mean, it is so easy to get the information that we need to get to clients. And the time constraints, they're just there. But being able to send information afterwards, whether it's a pre-canned handout or something that's typed up specifically, it is so nice to be able to give something from a trusted source to the family so that they're not Dr. Googling and now thinking the worst case scenario about a disease that's actually potentially really treatable.
If you were to, what do you think you would want your legacy in this profession to be?
Ooh, that's a heavy question. I mean, compassion and teaching have, you know, really always been tenets of who I am and what I do and what I try to leave behind at every job I'm at. And it's what's led to the development of DVM Stat on a much broader level. And so being able to have the impact of supporting as many veterinarians as possible by educating and empowering them to be able to manage complex cases really is what I have set forth as my mission since I finished residency.
Last question. What is one irreplaceable truth you have learned that every early career professional would like to hear?
It is always okay to say that you don't know the answer to something. It's okay to tell a client, I don't know the answer to that, but I'm going to go research. I'm going to talk to some people who have more experience with this area than I do, and I will get back to you with detailed information. It is okay to tell your team, I haven't seen this case. Maybe I saw one in vet school, but that was X number of years ago, or I heard about one time at a conference, but I've never seen one in real life. No one expects us to know everything. And I think that is an unhealthy dose of stress that a lot of us as type A personalities give ourselves, that we're supposed to know all and be walking textbooks. But the reality is that it is okay to lean on others to help bolster your ability to practice at a high level, and that there are resources around to do so.
Well, Dr. Kristin Welch, VetMed Stat, I can't thank you enough for being here. Now, I really want to make sure I pump up your product because I think the concept of telemedicine specialty is amazing. I wish it was around 15 years ago instead of just putting a message in and hoping that I get a call back within 24 hours. So I want to know, where do I find you online, on socials? How do I get a hold of you? How can we get the word out that you truly are out there and you're ready to work with veterinarians?
Yeah, so our business is DVM Stat Consulting. Our website's dvmstat.com. We're on Instagram as at DVM Stat Consulting, and LinkedIn the same. So we would absolutely love to work with any veterinarians that have not yet experienced working with telespecialty. It's a really, really easy thing to work into your everyday practice, and that's what we're here for. We're here to support you in practice.
Yeah, and I just want to say to everyone, what Dr. Welch has told us is basically it's about opening up and keep showing up. And maybe that's truly the definition of critical care at this point. And I just can't thank you enough for everything you said. It's been a wonderful, wonderful conversation. I enjoyed it so much. And to all our listeners out there, if you have any questions for Dr. Welch, you can also hit me up on you can DM me, you can leave a message, you can leave a comment. Irreplaceable Truths on YouTube. I hope that going forward that we have more of these deep conversations, because I think they need to be had for this profession for sure. And to all the listeners, we'll see you next time.